kind of help a veteran with healthy coping responses as an alternative to suicide. And my efforts at the VA is a lot of advocacy and outreach. I work with places in Delaware, a lot of homeless organizations like Home of the Brave, Warriors Helping Warriors, um, Delaware Center for Homeless Veterans, because a lot of the issues that surround substance use co-occurring disorders also lead to homelessness. So we have all these problems that once we start to address some of them, help the likelihood of advancement in the other issues. And, I think some of the issues with stigma that we deal with, veterans as a hyper masculine type of organizations that we come from, is we don't know how to ask for help and we don't know what to do. We don't know where to go. So that's part of my job duties is kind of helping people get there without um, the stigma. Like I was talking about earlier, one of the unique issues is reduction of support when you leave the military. My friend Honeycutt committed suicide when he left the military. At all the people that I know who have committed suicide, except for one, it was post discharge. So they're leaving these situations and having trouble adjusting to home. And just something to think about in terms of like stimulant use and substance use. How's your job change when a veteran is 100% service connected and receives $3,000 at the beginning of every month? Um, that can change a lot when our consequences are being diminished and working with substance use. And then that brings up secondary gain. Do people lie about symptoms to receive treatment to gain service connection? I'm sure there's a lot of that going on. And there's benefits to staying sick and receiving ongoing care because uh, veteran service connection can be reevaluated. If you don't know what I'm talking about in terms of service connection, when a veteran gets out of active duty service or out of service in general, they can apply to have financial compensation to for any type of disorders or physical problems incurred during service. So if somebody has post-traumatic stress disorder and they're unemployable and they're deemed 100% service connected, they would get that financial compensation once they leave service. So when I was beginning my LCSW training, my supervisor talked about difficulty in working with stimulant use disorders with service connection because of that influx of finances at the beginning of the month, and that being especially hard for stimulant use disorder because it of the role money plays in it. And again, I put the increased risk for suicide because that's something that we address commonly at the VA on all levels of behavioral health. Um, so the process that I use at Wilmington, if a veteran is requesting mental health services or referred to us, they have to have had behavioral health services within the previous year. They need a mental health assessment. If they're just coming in from maybe a transitional care manager and they just got enrolled with VA, they would still need a mental health intake. Once a mental health assessment is completed, they would be referred to the appropriate care. A lot of the times, um, I'm receiving referrals for people who have the co-occurring disorders. I mean, it's just the nature of the beast, you know. And we are often, you know, working with all disorders, whether it's through like CBT or motivational interviewings. Like I think somebody said in an earlier plenary presentation, should be involved with all of the mental health treatment. Uh, you know, I don't personally have any EMDR, CPT, or prolonged exposure professional certifications, but I can refer to those who can. And currently, we're referring all of our veterans requesting PTSD treatment to local vet centers. And similar to ASAM, they want us to try and use outpatient before we do inpatient. As part of follow-up care, part of my duties is to see veterans within 7 days of discharge from any medical type hospitalization. So I'm contacting veterans via telephone now because of all of the telework that we're doing, trying to engage them in care at all levels of treatment. You know, I work with people who are in the medical floor, people who are discharged from the medical floor, post residential treatment, post IOP, and trying to engage in care for ongoing treatment as well. And depending on their status, we're required to contact them between 2 and 4 times within 30 days following discharge, as an effort to try and engage veterans in treatment more so. So if they're high risk, we'll have flags pop up in our system. Something called Reach Vet uses an algorithm throughout the whole United States to try and identify risk factors for veterans. So we contact those veterans more than we might somebody who is just engaged in VHS originally. And of course, if there's suicide attempts, if they're high risk for suicide, we contact those veterans more. This is the number for the Veterans Crisis Line. This is something that we give out to all of our veterans. Any veteran can use it. If you just press 1 at the prompt, that will connect you with one of the workers. I think there's 3 locations now for suicide crisis workers, and eventually those get turned over to our suicide prevention coordinator, who can formulate a plan for those veterans or try and figure out something to engage them in care. And then that's all I have for today. I appreciate everyone allowing me to come and have a presentation.
All right, thank you very much, Michael. I appreciate it. So I just wanted to kind of talk about the poll results. So we put a poll up here. The question was, are you a veteran? And that came up as 45, which is 96% are not. And then we also have 2 that are veterans. So we want to thank you for that. I'm going to end that poll. And then I'm actually going to bring another poll question over. And there's a new poll, and it just asked if you did serve, which branch of the service did you serve in? So at this point, again, thank you, Michael, for your presentation. We're going to jump over and change the presentation. Give me 1 second here. All right, we're good to go. And if you would, Doctor, you'll have to go unmute. Thank you.
Okay, thank you, and thank you so much, Robert. And I want to thank Michael for an outstanding presentation that gave a perspective not only of VA, but the challenges our nation's heroes face when they come back home and transition from military service. And my presentation will take more of a national perspective, but before doing so, I want to express my condolences to Michael and to all of our veterans in attendance for the loss of their comrades, their fallen comrades. We owe them a great debt. And Michael, congratulations on your continued recovery. That's wonderful news. So without further ado, let's talk a bit about contingency management, which is an evidence-based treatment for substance use disorders. I happen to serve in the Corporal Michael J. Crescenz VA Medical Center in Philadelphia, where I serve as the education coordinator for the Philadelphia CSATE, the Center of Excellence in Substance Addiction Treatment and Education. We are an organization within VA that is committed to quality improvement in the treatment of substance use disorders. And one of the missions we have is the implementation nationwide in VA of contingency management. In terms of disclosures, I'm a full-time VA employee. I have no potential conflicts of interest. Just to give you a sense of the challenges that our nation's heroes face, those being served in VA, and specifically the Veterans Health Administration in terms of substance use disorders. As you could see from this graph, while cannabis use disorder certainly is the most prevalent and growing at a very rapid rate, in addition, what we see is a very rapid rate of amphetamine use disorder, in particular methamphetamine, whereas cocaine and opioid use disorder have plateaued a bit, some growth there. Methamphetamine misuse is quite a growing problem, and in fact, in some areas of the country, the CDC has reported that stimulant misuse, in particular methamphetamine, is implicated in many fatal overdose experiences, in some cases even more so than opioids. So it's really a national crisis that clearly affects veterans in VHA care. And this stimulant misuse actually causes an impairment in the patient or veteran's brain function. This is a PET scan from studies done by Dr. Nora Volkow of the National Institute on Drug Abuse. And what this shows is the areas of the brain that are use the neurotransmitter or neurochemical dopamine, what's sometimes referred to as the pleasure chemical. It's the areas of the brain that are activated by stimulant use, but also among folks who don't use stimulants, it's the area of the brain that activates whenever we engage in a pleasurable, rewarding experience. And in a person who is healthy and not using stimulants, you see those areas of the brain are quite active and functioning properly. But in comparison, a patient who misuses stimulants sees an impairment in that area. Now, what does that mean from an experiential perspective? What that means is that what was formerly rewarding to the patient, relationships, work, hobbies, food, any involvements that the patient formerly engaged in that were a rich part of their healthy life, do not produce sufficient activity in those pleasure areas of the brain, the dopaminergic areas as we call them, that they are displaced by the substance use, the stimulant misuse, because those other activities are just not feeling rewarding any longer or very insufficiently rewarding to the patient, whereas the stimulant misuse is squeezing what little bit of dopaminergic activity is still ongoing in those areas of the brain. The good news is that the brain can heal. Again, when we look over time, the areas of the brain that mediate pleasure, a sense of rewarding activity, return to near normal function. But as you could see in this slide, it takes time. 14 months after a patient is abstinent from methamphetamine, the brain starts to appear comparable to a patient who's never used methamphetamine. So we have a challenge before us. The brain reward that's associated with substance misuse, stimulant misuse in particular, is immediate, it's reliable, and it's powerful. Whereas in contrast, the rewards for abstinence, better health, better finances, better relationships, engagement in vocational activities, those consequences, which are powerful, are at the same time delayed and unreliable. They're not certain. They're not guaranteed. So it's almost as if the patient struggling with substance use disorder has the devil and the angel on their shoulders. The substance use is promising immediate reinforcement. I'm going to make you feel good, and or I'm going to take away your pain. And the angel is saying, well, if you just hang on long enough, your brain will heal, and some things in your life are likely to improve. And that is a real dilemma. It's a dilemma at the brain level. It's also a dilemma at the behavioral level. At the same time, what complicates the matter is that these substance use disorders that patients are struggling with are chronic illnesses, very much like diabetes or hypertension, and as such, they respond best to ongoing care. Because, for example, if a patient with hypertension or diabetes were to adhere to their care in an intermittent fashion, they're likely to see a return of their symptoms. Like the same is true with patients struggling with substance use disorders. Now, there is no FDA-approved medication for stimulant use disorders. We just don't have an evidence-based medication to treat stimulant use disorders. So the dilemma is starting to grow even more daunting. At the same time, though we want to retain patients in treatment because it is a chronic illness, substance use disorder, we see dropout or attrition from treatment at very high rates. More than 70% after just 4 sessions among outpatients in substance use disorder treatment. Now, you think back to that slide a moment ago where it takes 14 months in many cases for a patient's brain to heal. 4 sessions is just not going to be sufficient. So we come to the crux of our dilemma. How do we make early recovery sufficiently rewarding so that the patients remain in care while their brains heal, so that when the brain heals, then the formally reinforcing activities like relationships and work and hobbies can feel reinforcing to the patient once again? Well, one solution is an evidence-based treatment known as contingency management. Now, this treatment, in fact, just about everything you ever wanted to know about contingency management, you could find in a Psych 101 textbook. It is based on the most fundamental principles of behavioral science. That is, if we want a healthy behavior to occur frequently and repeatedly, you want to reinforce it. You want to reward it. So, for example, we want to reward drug abstinence that's verified by drug testing, or we might reward group therapy attendance. Now, the likelihood that those behaviors, for example, abstinence, will increase not only depends on providing a reward, but we also have to attend to the size of the reward, the timing of the delivery of the reward, as well as the exclusivity of the relationship between the behavior and the reward, such that if we give a delayed reward, to insufficiently large or small rewards, or if the person can get similar rewards from a variety of behaviors other than the one we're trying to promote the learning of, the learning is not likely to take place. So while it's fundamental, while CM is based on fundamental principles, what is key is the methods. The methods matter in the delivery of contingency management. And the model of contingency management that VA uses is known as the PrizeCM model. Sometimes it's referred to as the fishbowl CM model. Now, to understand how revolutionary this model is, and it was developed by the late, great Dr. Nancy Petrie. Dr. Petrie was a giant in behavioral health care, a giant in behavioral science. Sadly, we lost Dr. Petrie back in 2018 after a very lengthy and brave battle with breast cancer. But she left a legacy that includes this PrizeCM approach, which really revolutionized things. Well, am I overstating that? Well, consider this. Before Dr. Petrie introduced this PrizeCM approach, the way you would reinforce a behavior for a patient struggling with substance use disorder is when the patient submitted urine samples that tested negative for the target substance stimulants, they would get a prescribed and escalating dollar value of reinforcement. So for example, for the first urine sample I present, I might get $5. For the second in a row, I might get $8. For the third in a row, I might get $12 and so forth. Now that system of contingency management, it's known as voucher CM, is very, very effective. The problem is that over 12 weeks of twice weekly sessions, which is a typical course of contingency management, the costs in incentives could run anywhere from $800 to $1,200 per patient. Now, I'm sure we'd all agree that $1,200 spent in arresting a stimulant use disorder is money well spent, but good luck implementing that, especially in publicly funded programs where resources are quite limited. So for the longest time, that was the great lamentation about CM, is this terrific treatment that was difficult to implement because, frankly, it was just too costly. And those of us who worked in CM, I was both a provider and a supervisor of that form of CM, we kind of shrugged our shoulders and said, there's not much that can be done. If you want the behavior, you got to pay for it. It's sort of the Jerry Maguire principle. You got to show me the money. And lamenting it would be no better than when Captain Kirk would call up to Scotty, more warp power, and Scotty would say, I cannot change the laws of physics, Captain. Well, we would say, we can't change the laws of behavior. You got to pay for it. Well, we thought we were so clever until a real genius by the name of Nancy Petrie came along, and Nancy said, hold on a second. I have a way that we can provide reinforcement without sacrificing the success, but at a lower cost. And that was heresy in behavioral science. More behavior at a lower cost with less reinforcement, it made no sense. But as is the case with all true geniuses, Nancy saw the answer hiding in plain sight. And the answer was introducing probability as a means of determining the size of the reinforcement. And the way Nancy did that was, instead of the patient receiving a prescribed and escalating dollar value of reinforcement for their abstinence, instead the patient makes increasing numbers of draws of prize slips from a container, typically a plastic fishbowl, hence the term fishbowl CM, that contains 500 of those prize slips. As you can see from the slide, half the prize slips have no dollar value. They're worth no money, but there's 250 of them. 209 of the slips are worth $1, 40 are worth $20, and one of the 500 slips is worth $100. Now, draws start at 1 for the first negative sample, and they escalate, and that escalation is very, very important. If we were to provide a static amount of reinforcement, $5 each time the patient tested negative, or 1 draw every time the patient tested negative, what we would likely get is intermittent abstinence, because there would be no differential value from the patient's perspective for consistency. But by escalating the number of draws, we're not only reinforcing that episode of abstinence, we're reinforcing consistency. That is key. Why? Because what we're trying to produce is the longest duration of abstinence possible while the patient is in treatment. In fact, that longest duration of abstinence, known as the LDA, is among the best, if not the best, predictor of a good prognosis for patients in substance use disorder care. The longer the period of abstinence during treatment, the greater the likelihood of success when treatment concludes. And there's really nothing mysterious about that. What we're doing is, again, creating the opportunity for the patient's brain to heal, and also creating the opportunity for the patient to practice living again without the substance, so that the brain is healing and the patient is receiving reinforcement for engaging in activities that support their recovery, that ultimately produce the abstinence. When the abstinence is not verified, we actually introduce, through PrizeCM, another learning element, which is extinction. Again, thinking back to Psych 101, extinction is when you provide nothing after a behavior occurs. So when drug consumption occurs, when the patient engages in stimulant use, they get nothing. And in addition, after the patient tests not negative or has used stimulants, not only do they not get anything at the time of that positive test, but the amount of reinforcement they get next time they test negative resets back down. So it escalates with consistent abstinence and it resets with use. Now, what that does is it introduces a third learning contingency. Again, we have positive reinforcement. If I'm abstinent, I gain something. We have extinction. If I'm not abstinent, I get nothing. And then we have negative reinforcement. In other words, reinforcement by avoidance or escape. And the way that works in CM is I am reinforced positively by the draws I make from the fishbowl when I test negative, but I'm also reinforced by avoiding the reset of that number of draws back down to the lowest level. In fact, negative reinforcement is a very potent learning contingency. It's something we experience in our lives, maybe on a day-to-day basis. For example, whenever you get into your vehicle and you neglect to put on your seatbelt and you start the ignition, what typically happens? You hear a buzzer or a chime or a bell, and it keeps going on and on and on. It's not particularly pleasant, and the only way to stop it is by clipping your seatbelt in, either before you start the ignition or after you started the ignition. That's the automakers using negative reinforcement to promote seatbelt use. Well, in CM, negative reinforcement comes in the form of the avoidance of the reset. So with Nancy Petrie's model, we're using 3 learning contingencies: positive reinforcement, negative reinforcement, and extinction. But most importantly, in terms of implementation, the cost of this form of CM over 12 weeks of twice-weekly sessions is $200 per patient. That is what allows an organization like VA to implement this treatment at a very large scale, which we have done, versus, for example, the voucher CM, which could cost as much as $1,200 per patient for a 12-week course of care. Well, what effect does CM have? Well, let's first address the science behind CM. What does the empirical literature on CM say about its effectiveness? Well, I cite 2 meta-analyses. Meta-analyses are studies where a group of previously published studies are grouped together to look for how effective the treatment is. And through statistical methods, you identify a sort of cumulative effect of the treatment. And what these 2 meta-analyses showed is that the effect size is roughly from 0.42 to 0.58. What does that mean? That means anywhere from a 22 to a 28% improvement in outcome. To bring that into more plain clinical terms, in comparison, that is roughly equivalent to the effect size of antipsychotic medication on schizophrenia. So we're talking about a pretty robust effect. In fact, in the meta-analysis conducted by Dutre and colleagues, the strongest effect among psychosocial treatments for stimulant use disorder was found for CM. And bear in mind, again, we don't have the FDA-approved medications for stimulant use disorder. So really, CM is the best treatment we have, period, for stimulant use disorder. So VA, back in 2011, decided it was going to have a massive nationwide effort to implement CM in its substance use disorder treatment programs. That effort was started by identifying the need for CM. And in 2010, VA sponsored a RAND study that showed that although CM was an established evidence-based treatment in the scientific literature, only roughly 1% of veterans in VA addiction treatment systems had CM available to them. So there was a good treatment, but it wasn't really available to the veterans. Well, in response to that, the VA allocated resources, both fiscal resources and human resources, to support the implementation. Funding was made available to train personnel and also to purchase supplies needed for CM, the incentives, the testing supplies. And the organization I work for, the CSATE, was tasked with coordinating this national implementation effort. In addition, VA also incorporated implementation mandates into its policy. In fact, the VA policy recognizes CM as an evidence-based treatment, and this is a quote, that when clinically indicated must be available to all patients meeting locally established patient inclusion criteria. that are consistent with published evidence. That is a strong endorsement of a treatment that I'm not aware of is in existence in any other healthcare agency in America. Well, about 55 months after the first CM programs in VA got underway, which was roughly June of 2011, we published the outcomes that we saw in VA. And by that time, from June 2011 through December of 2015, VA had provided CM to roughly 2,060 veterans in 94 of its SUD treatment programs. 50% of CM patients completed 14 or more CM sessions in a 12-week period. In comparison, patients who don't get CM, only 42% of them complete more than 2 sessions in a 1-year period. So we were seeing a very important improvement in attendance, and in terms of substance use outcomes, roughly 92% of the nearly 28,000 urine samples that we had collected nationally at that time tested negative for stimulants. What about most recently through the end of fiscal year 20? We're up to 111 stations having made CM available. We've treated over 5,400 veterans. Over 92% of the more than 70,000 urine samples we've collected have tested negative for the target drug. We've expanded it to include cannabis, but we also, of course, treat stimulant misuse. In terms of retention, we are retaining patients in treatment roughly 6.5 weeks on average. Again, by comparison, only 42% of patients without CM get more than 2 sessions of care in a year. And this is just an example de-identified of the type of feedback we've received from veterans who have received CM. Personalized thank you letters for making this treatment available. Providers also have been very receptive to CM. Who doesn't like to reinforce and provide prizes for behavior? And these are just some of the quotes from programs across the country. And I want to thank you and take any questions you have.
Appreciate it. So we'll get started on the questions at this point. So question number one. Give me 1 second here. Question is there any cadence to the belief that stimulants were given to soldiers in the field to help them remain alert and promote aggressive tendencies? So I don't know which one of our panel would like to take that question there.
Michael, would you care? I have some thoughts on it, not direct evidence, but some thoughts. In terms of what, it might be apocryphal. I think this actually, part of this evidence actually dates back to World War II, where there's some evidence that actually the Nazi war machine actually used methamphetamine among its soldiers to fight fatigue and gain a potential battlefield advantage. I've also heard, and this may be apocryphal, so I don't know this is evidence, that sometimes stimulants were used for pilots on long-distance flights or bombing runs. Again, that may be apocryphal. I don't have any evidence of that.
Next question is, Luzerne County Community College has a collegiate recovery program. We had one veteran interested in participating, but he decided he didn't want their services. How can we reach veterans on the campus or campuses?
Michael, feel free. I'll be happy to chime in.
One of the things that I've noticed is that it was hard to reach veterans on campuses. When I went to school, I actually worked with Millersville to start a student veterans union, and they gave us a house, and it kind of opened up and got larger to where we had people coming in to give us resources, and veterans could go there during the day. Because I mean, I know, like for me personally, I lived off campus. I was non-traditional student, so somewhere for me to go in between classes if I didn't want to go home. Um, it just becomes working with the university to try and find the veterans population, in my opinion.
Yeah, I am a firm believer in raising awareness. So I think outreach efforts are crucial to reach veterans and patients in need across the country. So we have to make affirmative efforts to reach these veterans. And I think, for example, working with veteran service organizations, community organizations to reach veterans is absolutely key. And developing those relationships is an ongoing
All right, thank
mission that
you.
we have.
Real quick though, for the presenters, I would ask that if you're not speaking to put yourself on mute. It helps with the echo, if you would please. All right, next question. Aren't specific amino acids beneficial to restoring healthy brain activity?
I'm not aware of evidence per se of using sort of nutraceuticals, as they're known, basically pharmaceuticals based on nutrients, for example, amino acids. I think there's certainly in theory that makes sense, but I'm not aware of any evidence where nutraceuticals have proven to be an evidence-based treatment. In fact, in the VA and Department of Defense clinical practice guidelines, they are not mentioned as an evidence-based treatment. So that's about the limit of my knowledge of that. That would be more of a biochemist's, psychopharmacologist's area of expertise. But I'm not aware of any evidence on essentially what amounts to a randomized clinical trial of nutraceuticals for establishing healthy brain function. At the same time, we know that just good nutrition is often neglected, especially among patients with stimulant use disorder, because of the suppressed appetite and the increased alertness and psychomotor activity. So there's severe weight loss, there's severe dental decay, there's severe atrophy of muscles. So certainly good nutrition should be a part of the patient's recovery plan.
Thank you. Next question is prior to discharge from service, do veterans undergo any evaluations to determine whether they may need help before or after discharge?
Michael, would you like to?
I think we always are constantly making evaluations whether they need further assistance post discharge. I think that's part of treatment planning in itself, is trying to manage goals and update goals as they go. It's a living document, as it were, and we're always looking to provide follow-up care as needed, especially if it's not a service that we can provide ourselves.
For the panel, the question might be more of prior to discharge from service, the military service, are you aware of any evaluations that occur with either the Marine or the soldier or the Navy seaman or whatever rank it might be prior to them being discharged from the military service?
So you can apply for service connection prior to your discharge, and but you have to kind of be able to recognize some of the things that you're experiencing yourself. They won't necessarily be told to you. So a lot of the times these things are coming up years after discharge, and you have to try and identify that they were service connected or service related. They do give classes before you get out of the service. At least in my branch, they did. We went to a 2-day class on resume building and how to do this and how to do that. But nothing specifically for me when I got out in 2006 directed me to how to get enrolled with VA services. I think that's what's huge with like our transitional care managers and those types of social workers and nurses is that they try and reach people that are not enrolled in VA services in order to get them the care that they need.
I don't know, doctor, if you would like to have any additional information.
Yeah, I think there's some effort now, especially as I recall in the area of surveillance for post-traumatic stress disorder, some efforts to assist discharging or transitioning veterans from active duty service to veteran status. But I don't know the specifics of what the Department of Defense is doing in that regard.
I'll speak very briefly from a personal perspective. I know when I returned, um, it was very difficult from the standpoint of you just wanted to be done. You wanted to move on. Any evaluation that would limit or restrict your ability to just continue to move forward, you were very hesitant to provide any additional information because you were just looking forward to moving on, and any evaluation that would get in the way of that occurring was an evaluation that the service person not necessarily would want to be involved in. Thank you both. Next question. If there is a limit of $75 per year, how can we adapt CM models?
Great question. And indeed, the Federal Department of Health and Human Services currently caps incentive costs at $75 per patient per year. Now, we know from the literature on CM, in fact, a study that Nancy Petrie published back in 2005, I believe, where she compared CM with, in essence, a cap of $80 of incentives versus CM with a cap of over $200 in incentives. And the patients in the branch of the study that received the $80 capped CM, they did no better than treatment as usual and not having CM at all. So I'm skeptical that you can implement CM effectively, at least abstinence CM, with that cap in place. At the same time, I understand, and again, I'm VA, not Health and Human Services, but this is public information reports I've seen that Health and Human Services is soliciting feedback on the cap. So I think it's certainly it remains an open question about how that may or may not change over time. But we know the evidence suggests that $75, of course, should not be would not be effective because we already know that $80 is not effective. Now, you could certainly try to craft a CM system that uses that is within that $75 cap, but it would not. You could not consider it an evidence-based application of CM because it would be implementing CM with an active ingredient that we know is not effective. $80 or $75 is just, from the literature we know, is not terribly effective. In fact, not effective at all compared to treatment as usual.
Thank you. Next question. Does effectiveness of CM decrease if used over the whole continuum of service? Inpatient, IOP, and then outpatient.
Great question. In fact, on the contrary, that is actually a very good application of CM to promote the continuity of care across different levels of care. So it's perfectly appropriate to commence the CM when the patient is in the highest level of care and inpatient service, continue it into residential care, continue it into outpatient care. Now, at the same time, in terms of implementing CM in a service that is essentially a very controlled environment, the question becomes one of clinical need. If the controlled environment of, say, a residential program is sufficient to arrest substance use among the residents, then adding the CM would be clinically superfluous. It wouldn't do any harm. It's just not going to give you a differential clinical impact. In that case, what we would recommend is that the CM be commenced just prior to the patient discharging from the residential program, say in the last 2 weeks of the residential program. Presumably, the patient is going to test negative for those 4 sessions. Remember, CM is twice a week for 12 weeks. So there'd be 4 sessions of CM commenced at the end of the patient's residential stay. They're very likely to earn reinforcement because they'd almost certainly be testing negative. And then the CM would bridge into outpatient care and help avoid a major challenge that we see among patients that complete residential program, and that is discontinuity of care. And many of those patients then suffer a relapse back to their substance use and oftentimes return to the residential setting in a clinical condition that is more severe than their previous baseline. So we want to bend that curve back towards continuity of care and help stop that revolving door, because obviously it has impact on the patient's quality of life and also the capacity of the system to serve as many needy patients as possible.
All right, thank you. Next question is, it appears that the fishbowl method of contingency management also uses intermediate reinforcement as a factor. Have any comments on this?
Yeah, in fact, PrizeCM is sort of unique among schedules of reinforcement. Again, thinking back to Psych 101, you have continuous reinforcement schedules where you receive reinforcement every time you engage in the behavior. And then there are partial or intermittent schedules, like, for example, a slot machine is an intermittent schedule of reinforcement. We know that for learning a behavior from the start, for the acquisition of a behavior, continuous reinforcement is the best schedule. For sustaining the behavior, intermittent reinforcement is the best schedule. Now, in terms of the PrizeCM model, you could actually argue it has a continuous reinforcement approach, because every time the patient is abstinent, the patient makes draws, and the draw process is reinforcing because it is associated with the opportunity to earn reinforcement. So where I think the future or the frontier of CM is moving from that continuous reinforcement schedule where you're coming to the clinic twice a week for 12 weeks and making draws contingent on testing negative for the stimulants, moving that out into the community on an intermittent schedule where, for example, a patient might get a ping on their smart device saying, once every 30 days you get this announcement, please provide evidence of your abstinence. You know, maybe a self-testing oral fluid sample might suffice, and you'd be supplied remotely and immediately reinforcement. So I think we can certainly consider, especially with now the technological advances we have, consider moving from that continuous reinforcement schedule to an intermittent reinforcement schedule where the interval grows and grows and grows and supports abstinence and recovery longer term.
All right. And we have time for one last question, and that question is the fishbowl replaced after each session?
Outstanding question. Indeed it is. That's a great question, because when you think of it from the patient's perspective, if I, at my first sample testing negative, making my single draw would have hit the jumbo, my excitement would quickly give way to disappointment because I'd realize, oh gosh, I'm never going to be able to get this jumbo again. So indeed, draws are done with replacement to maintain the opportunity for high-value reinforcement throughout the patient's course of care.
Thank you. Again, I want to thank both presenters here today for your time and your effort and your presentation. I certainly appreciate it on behalf of the Commonwealth and the Department of Drug and Alcohol Programs, your time and your efforts in the presentation today. Thank you again. And at this point, this closes this breakout session. Thank you. Thanks, gentlemen.
Robert, do you want us to stick around for a moment for debrief or anything, or?
If you have any specific questions or anything like that, I certainly appreciate it. I'm not sure if you're going to continue with anything else as it relates to the symposium or not.
No, unfortunately,
you're more than welcome to do that.
Oh, I appreciate that. Thank you.
Again, Dom, I certainly appreciate it. It was wonderful. You did a
Oh, my
great job,
pleasure.
and I learned some things on
Thank you.